Good evening, everyone. We are back with another case related to gynecology. This is the fifth case, and it is a case study on tubal obstruction. Our patient is a 31-year-old female who had complaints of primary infertility. The woman has regular menstrual periods, bleeding for 4 days every 28 to 30 days. Her periods are not heavy and have never been painful. There is no intermenstrual bleeding or discharge and no postcoital bleeding. Her last smear was normal. Social history: she is a non smoker and drinks alcohol very occasionally. The partner's only previous medical history was an appendectomy and a course of anti helicobacter therapy after he developed epigastric pain and was diagnosed with the infection. He previously smoked 20 cigarettes per day and drank up to 28 units of alcohol per week, but has now stopped smoking and significantly reduced his alcohol intake. It is considered that men who smoke have reduced sperm concentration, reduced motility, fewer normally shaped sperms, and increased sperm DNA damage. So, sperms take up to 90 days to develop. By quitting smoking 3 months prior to an attempt to conceive, it will significantly improve the health of the sperm. Objective data: on examination, the woman has a body mass index of 23 kg per meter square. There is no hirsutism or acne. There are no signs of thyroid disease. The abdomen is soft and non tender. Speculum and bimanual palpation are unremarkable. Genital examination of the partner is also normal. Her lab parameters involved follicle stimulating hormone and luteinizing hormone was all normal. Her day 21 progesterone was 45 nanomole per liter. If the day 21 progesterone is above 30 nanometer per liter, it shows that ovulation has occurred. Prolactin is normal. Her testosterone was also normal. The semen analysis of her partner was performed, and the volume, count, motility of the sperms were all found to be normal. She is immune to the rubella and she has negative chlamydia infection. Specialized diagnostic tests: hysterosalpingogram was performed. It is an X ray procedure that is used to view the inside of the uterus and fallopian tubes. It is used to see if the fallopian tubes are partly or fully blocked. In this, a dye is used and it is used to see whether the fallopian tube is blocked or not. And in this patient, tubal obstruction can be seen since the spill is not observed. Assessment: the diagnosis: on the basis of subjective, objective, and lab data, the diagnosis was made to be fallopian tube obstruction. Day 21 progesterone above 30 nanomole per liter confirms ovulation, and this is supported by normal follicle stimulating hormone, luteinizing hormone, and prolactin. Normal testosterone suggests that polycystic ovaries is an unlikely diagnosis. The semen analysis is normal, and therefore any male factor etiology is unlikely. Rubella immunity should always be confirmed. The hysterosalpingogram shows fill of contrast medium into both uterine tubes, but no spill, suggesting tubal obstruction as the cause of the fertility problem. Need of therapy to improve patient's quality of life to manage her infertility. About tubal obstruction: fallopian tube obstruction, also known as fallopian tube occlusion, is a major cause of female infertility. Blocked fallopian tubes are unable to let the ovum and the sperm converge, thus making fertilization impossible. Approximately 20% of female infertility can be attributed to tubal causes. Distal tubal obstruction, affecting the distal tubal opening towards the ovary, is typically associated with hydrosalpinx formation and often caused by Chlamydia trachomatis. Hydrosalpinx is the filling of fluid in the fallopian tubes, which causes a sausage like structure. Pelvic adhesions may be associated with such an infection. In less severe forms, the fimbriae may be agglutinated and damaged, but some patency may still be preserved. Mid-segment tubal obstruction can be due to tubal ligation procedures, as that part of the tube is a common target of sterilization interventions. Proximal tubal obstruction can occur after infection such as septic abortion. Management and intervention. Tubal blockage on hysterosalpingogram can sometimes be due to tubal spasm, and therefore a laparoscopy and dye is needed to confirm the pathology and also to determine a cause such as adhesions from previous infection or possibly endometriosis. Although the history does not support this diagnosis, if the tubes are found at dye test to be patent, then this would suggest that it is feasible to attempt pregnancy with in utero insemination. However, if blocked tubes are confirmed, then in vitro fertilization is indicated. Abnormal tubes are usually removed prior to IVF, as success rates for pregnancy are better and ectopic pregnancy rate reduced after bilateral salpingectomy. The women should be given to take folic acid 400 microgram daily to reduce the risk of neural tube defects and to the partner to minimize his alcohol intake. In this case, the laparoscopy showed bilateral hydrosalpinges and adhesions as well as perihepatic violin string adhesions. These findings are consistent with previous infection with chlamydia or more rarely gonorrhea. Hydrosalpinges is the filling of fluid in the fallopian tube, and perihepatic violin string adhesions is usually found in pelvic inflammatory disease in the females. It is not unusual to find such severe pelvic adhesions, even when there has never been a clear clinical history of pelvic infection or sexually transmitted infection. Although the infection may be long ago, it is sensible to treat both the woman and her partner with a course of antibiotics for pelvic inflammatory disease. Thank you.